the ESO guideline on the unruptured aneurysm, and the speaker is Gabriel Rinkel, professor of neurology at the University Medical Center in Utrecht, the Netherlands. Please, Gabriel.
Thank you very much for the introduction, and it's happy to be here and to be here on behalf of the entire team that you see here. And before I present the team to you, I want to give our disclosures, and usually that slide goes very fast, but I think it's important that you realize the disclosures we have. And 3 of us are involved in the PROTECT-U study. That's a randomized trial on treatment with aspirin and blood pressure lowering in patients with unruptured intracranial aneurysms. And that is me, Professor Edminon, and Dr. Vergouwen, and Romain Bouchier is the coordinator of the UCAN study, a study on follow-up of unruptured intracranial aneurysms and vessel wall imaging. We have no financial disclosures. This is the entire team, and we've been working closely together over many years to provide these guidelines. There are a couple of deadlines that we didn't meet, but fortunately for this meeting, we met the deadline. The team consisted of 5 neurosurgeons, 2 who also perform endovascular treatment of aneurysms, 2 interventional neuroradiologists, and 4 neurologists, and we were from 7 European countries. So to set the idea, it is on ruptured intracranial aneurysms, and what we want to avoid and afraid of course, is rupture of the aneurysm that provokes subarachnoid hemorrhage, and as you can see in this example, that often leads to a poor outcome, being death. And that is what we don't want to see. So we developed a couple of important questions, we thought, and the first was, should we, in a patient with an unruptured aneurysm, should we intervene? And as you can see here, that can be by clipping of an aneurysm. For those who are not regularly on a neurosurgical ward, these are 3 clips, or you can coil the aneurysm, or should we not treat the aneurysm? The second question, clinical question, was if we decide for treatment, should we do it by clipping or by coiling? The third question, if we don't do an intervention immediately, should we follow up patients? Also, if we have treated the aneurysm, should we follow up patients? And finally, what about lifestyle modification, smoking, hypertension, or medical treatment? And I have to, before we go into the questions in detail, I have to admit and I have to say that there is a lot of uncertainty here. There are not a lot of good quality studies on patients with unruptured aneurysms, so most of the quality level of evidence will be very low. So let's start with the first question. If we see a patient with an unruptured aneurysm, should we intervene, yes or no? You are aware from previous sessions that these clinical questions are translated into a so-called PICO question, and for those who are not familiar with it, PICO stands for the patient, I for the intervention, C for the control, and O for outcome. So the first PICO question was, in adult patients with unruptured intracranial aneurysms, does any type of microsurgical or endovascular aneurysm occlusion compared to no aneurysm occlusion improves outcomes? Well, for that question, there are no randomized clinical trials, and there are no observational studies with clinical outcome as an outcome measure, and there are only observational cohorts on risk of rupture, which is, of course, something else than clinical outcome. And there are a lot of observational studies on treatment complications. So that led to the question to balance the risk of aneurysmal rupture versus the risk of preventive aneurysm repair. And the recommendation we come up with is that in adult patients in whom the estimated 5-year risk of rupture is higher than the risk of preventive treatment modality, we suggest preventive aneurysm repair with the treatment modality that is most effective and safe for that particular aneurysm. And I give you a few seconds to digest that. If you have it, I go to how we came to that. Well, there are a couple of studies, as you can see here, that have assessed the risk of aneurysmal rupture at 1 year and also later on. And at 1 year, if you combine all those studies, as we did, it is a bit less than 1% per year. But there are also prediction models. One of those is the PhaSES score, and with that you can predict the absolute risk of rupture in 5 years. There are a lot of observational studies on treatment complications. There is one randomized clinical trial that provided until now only interim results with a 1-year modified Rankin scale as outcome measure. And in that trial, the risk of complications or the risk of poor outcome at 1 year was around 4% after endovascular and surgical treatment without a statistically significant difference between the two modalities. So that is the background to the first recommendation. There are no data on the size of or the volume of the treatment centers, but all experts agreed on the following expert consensus statement, being that for patients with unruptured intracranial aneurysms, we suggest that such patients should be assessed within a multidisciplinary setting, including neurosurgery, interventional radiology, and neurology in large volume centers, consulting at least 100 patients per year. So that is to intervene or not to intervene. The second main clinical question was, if we decide to intervene, should we do it by clipping or endovascular treatment? And that is the second PICO. So in adult patients with unruptured intracranial aneurysms, does any type of microsurgical occlusion compared to any type of endovascular occlusion improve outcome? Again, not a lot of data, interim results of only one randomized clinical trial, and there are a couple of observational studies on treatment risks. The recommendation is that in adult patients with unruptured intracranial aneurysms, we cannot make an overall recommendation that states which treatment modality is preferred based on the current data. And I'll show you why we came to that recommendation. You see here 3 studies that had both an intervention, both a surgical and a endovascular arm. The study from Darceau is a real randomized comparison, and the other studies are observational studies without a randomization between the two treatment possibilities. And you see that there is no statistically significant difference between surgical or endovascular treatment. What about the risk of treatment complications apart from this these interim results from the trial? We use data from a large meta-analysis. You see 114 studies with more than 100,000 patients and more than 100,000 aneurysms. And overall combined, clinical complications occurred in almost 5% of after endovascular treatment and 8% in surgical clipping. We have one other recommendation here, and that is if you decide for treating the aneurysm, what about flow diverting stents? And the recommendation here is that we suggest flow diverting stents only if there are no other endovascular or microsurgical options to occlude the aneurysm at a risk lower than the expected 5 years risk of rupture. So only if you really need to treat that aneurysm and there is no other possibility, then you should consider a flow diverter. And the evidence, not a lot of evidence, but the evidence behind that is that there is one randomized clinical trial comparing flow diversion versus the rest being coiling, parent vessel occlusion, clipping, or observation. So that's quite a diverse group. But that trial was prematurely stopped because of safety reasons and a lot of complications in the flow diverting stent arm. So apart from that recommendation, we have a consensus statement, again, that if you decide to treatment, that the type of treatment should be done in a multidisciplinary setting where the chance of complete aneurysm occlusion and risk of complications are openly discussed. And again, that in centers where more than 100 patients with ruptured and unruptured aneurysms are treated per year. And in more than 30, and that the neurosurgeon or the neurointerventionalist should do more than 30 of these procedures per year, per person. So if we don't intervene, should we do follow-up imaging? That is the third PICO. And the recommendation there, or again, the warning, there are no randomized clinical trials on that, and there are no observational studies with clinical outcome, and only cohort studies with aneurysm growth or outcome as outcome measurement. And the recommendation here is that in adult patients with an unruptured intracranial aneurysm in whom the treatment complication risk is higher than the risk of rupture, we recommend radiological monitoring to detect growth of the aneurysm or morphological change. Of course, only in patients in whom treatment remains an option, being that if the patient is 86-year-old and a small aneurysm is detected because of a TIA, you probably would not follow up that patient. The evidence behind that, or the data behind that, is that there is a considerable chance that an aneurysm grows during follow-up, and that if the aneurysm grows, there is a higher risk of rupture. And that is the second recommendation here, that if you see growth of an aneurysm, we suggest preventive aneurysm repair, but of course you still have to balance the risks and benefits of that treatment. And the reason for that is a recent study from Lara van der Kamp, published last year, that the risk of rupture after growth is, you can see here, 3% in the initial 6 months, 4% at 1 year, and 6% at 2 years. So a growing aneurysm has a high risk of rupture. Coming to the lifestyle and medication, you know that smoking and hypertension are risk factors for aneurysm and subarachnoid hemorrhage. So the question is there any lifestyle modification or any medical treatment to improve outcome in patients with unruptured intracranial aneurysms? Again, no randomized clinical trials on cessation of smoking, and there will never be a randomized clinical trial on cessation of smoking, because we will never say there's one arm that you continue smoking thus far. And there are no randomized clinical trials on treatment hypertension or on treating hypertension. So the recommendation here is that we recommend smoking cessation, and we recommend that strongly, even though there is only little evidence. And the same holds true for treatment of hypertension. And there is some background information for that from a large cohort in Finland. And the main data are here, that in patients with an unruptured aneurysm who continue smoking, 41% had an aneurysm during follow-up, and those who stopped smoking had no aneurysm. Of course, the confidence intervals are wider than this whole, but still these are intriguing data, and stopping smoking is good for your health anyhow. Regarding hypertension, the risk of rupture during follow-up is much higher in patients with uncontrolled hypertension and in patients with controlled hypertension, and you see the hazard ratios here compared to patients with no hypertension. Then regarding treatment with aspirin or statins, and I don't have supporting slides for that because of lack of time, but currently we suggest to not start with aspirin or statins to decrease the risk of aneurysm growth or rupture. But as I told you in the beginning, there is a trial going on aspirin treatment and blood pressure lowering. So more data will follow about aspirin in the coming years. However, if there is a good indication for aspirin or other platelet aggregation inhibitors, there's no need to not give them. And the other expert consensus statement is that in patients, we suggest to keep the blood pressure lower, currently lower than 130/80. Then the last topic, if the aneurysm is treatment, should we do follow-up imaging? And you see the PICO here. Is there any type of frequency of follow-up imaging compared to no follow-up imaging to improve outcome? Again, as you can imagine, no randomized trials. There are no trials comparing follow-up imaging versus no follow-up imaging after treatment of an aneurysm. And there are no observational studies with clinical outcome, but only cohort studies with aneurysm growth or recurrence as outcome. And the recommendation here is that for adult patients with treated aneurysms, we suggest an initial radiological follow-up 3 to 12 months after aneurysm treatment to detect remnants or recurrence. Very low evidence, but still we recommend it. And the reason behind that is that you see that there is a remaining risk of rupture if you follow up patients more than a year after treatment. And you see the proportion here. And there are a couple of cohort studies, one from South Korea showing that after surgical and endovascular treatment, there is a remaining risk of aneurysm or rupture. And if you take intracranial hemorrhage, so all hemorrhages altogether, there is after surgery and after coiling a remaining risk. So that is the basis why we recommend follow-up imaging. And these are the retreatment rates we found in the literature. And the expert consensus statement is that you should do it with MR angiography after endovascular treatment and with CTA after surgical treatment. Well, what should we do in the next decades? Well, there's urgent need for randomized clinical trials or sound comparative studies with relevant clinical outcomes. So not only aneurysm or rupture, but clinical outcome on preventive versus no preventive aneurysm treatment. I think we need really good investigator-driven studies on new endovascular devices and not only registration studies paid by the companies. And I think we need randomized clinical trials on medical management of unruptured aneurysms. And as I told you, one such trial aiming for more than 700 patients, 750 patients is underway. To conclude, we provide 13 recommendations, I've not discussed them all, and 15 expert consensus statements to guide clinicians when consulting patients with unruptured intracranial aneurysms in daily practice until more robust data become available. But there is a high need for proper studies in these patients. And with that, I would like to thank you for your attention.
Thank you very much, Gabriel, for a very clear presentation. I think we do have time for some questions. So are there some questions from the audience? Please stand up to the microphone.
Maybe no data, no questions? Oh, there is a question.
I think there's a question from Professor Danilotto.
Very shortly, my compliment, Gabriel, for this very nice guideline. I didn't see any mention about the size of the aneurysm. Does it matter?
Yes, size matters.
I know.
in many respects, but also for unruptured intracranial aneurysms. I showed you one slide on the prediction of the absolute risk prediction of aneurysms, and one of the main factors in that prediction model is size. Absolutely, yeah.
Okay, so it must be included in a general.
Yeah, because it is not only size, it is also size, okay. It is the age of the patient, whether or not previous subarachnoid hemorrhage, etc.
Okay. Thank you.
Thank you. Are there any other questions? So if not, I have a question for you. So would you take into account the psychological impact of the aneurysm on the patient and when you decide treatment?
Absolutely. And one of the expert consensus statements we had is that the team, the surgeon, radiologist, and neurologist should come up with an advice, and that advice is discussed with the patient, and that you should inform the patient as much as possible, and that it is a shared decision making. It's not the team that decides on the decision. The team gives an advice, and that advice is taken, is discussed with the patient, and there you can include the, well, anxiety or relief for the patient.
Can I quickly ask a question?
Absolutely.
Sure.
Yeah, with regards to unruptured intracranial aneurysms found as an incidental finding, documented somewhere, what about these patients if they require thrombolysis? Any such recommendations or thoughts?
Yeah, absolutely. If you have a patient with an ischemic stroke in need for thrombolysis and you see an aneurysm, there's only one thing you can do, thrombolysis. There's no risk that you will rupture your aneurysm with thrombolysis, and the patient will benefit from the thrombolysis.
Thank you very much. So I think that in the interest of time, we have to move on. And it is my